So I want to start by just welcoming everyone to the next in our series on the American Jewish experience in medicine. Some of you know that this program has focused on a variety of issues over the last couple of years. It's generously supported by Dr. Helen Morris, a remarkable American Jewish woman in medicine in her own right. Who wanted to really bring to light some of the ways in which medicine and the Jewish community intersect, and the influences that the Jewish people have had in the medical community. We had an original scheduled single speaker for today who canceled on us, unfortunately. And so we had such a wonderful response to the initial outreach on her topic, which was BRCA testing. That we felt like we could not just cancel the program. And so we scrambled over the last couple of weeks, and we found 3 people, each with a really remarkable and unique type of expertise to bring to this conversation. And I, for one, am just really excited to welcome the 3 of you to this platform and to have this conversation with you today about BRCA testing, its history, its legacy, the ways in which the Jewish community has played a role in its development and evolution, some of the scientific, sociological, political, ethical debates that have arisen as a result of the way that BRCA testing has been rolled out and studied and so on. There's just so many fascinating aspects of this story, and it's not done. It's an ongoing story that is still being deliberated today. So to get started, let me just start by introducing our 3 speakers today. Dr. Rachel Rabinovitch is Vice Chair for Clinical Research and a professor in our Department of Radiation Oncology and also our Department of Medicine at the University of Colorado and in our Denver Comprehensive Cancer Center. I will not read her entire bio. That will be posted in the thing. I'll just note that she is really an expert, a major player in our breast cancer clinic. She's written dozens of original articles and reviews and book chapters, and regularly presents her research at national and international scientific meetings where, again, she focuses on the care of women with breast cancer. Next on the list, I have Michelle Springer. Michelle is an instructor and a clinical genetic counselor with the University of Colorado's Hereditary Cancer Program. She's been a certified genetic counselor for over 24 years. And over the last dozen years, she's really focused her area of expertise, as well as she brings a lot of passion to the field of cancer genetics specifically. So she brings a really unique viewpoint to this conversation today. And finally, a great friend of the American Jewish experience in medicine. One of our favorite programs of all time was a conversation with Paul Wolpe, over a year ago now. But Dr. Wolpe is the Raymond F. Skenazy Distinguished Research Chair in Jewish Bioethics. He is a professor of medicine, pediatrics, psychiatry, neuroscience, and biological behavior, as well as a professor in sociology, and he directs the Center for Ethics at Emory University. And with regard to today's topic, it's especially notable that he is the ethics consultant for a group called JScreen, which is one of the big advocacy groups around screening programs for the Jewish community. So Paul, again, just brings a really unique and important perspective to the program today. To get us started, I think we have a very mixed audience here. Some people are health professionals and have been dealing with these issues for many years. Others are patients who may actually be grappling with whether or not to get BRCA testing. So I wanted to just start with a simple but complicated question to Dr. Rabinovitch and Rachel. I'll say, what is BRCA? What is this gene? What does it do? Why is it associated with cancer? Can you just start us off with some basics?
Sure. So the BRCA gene, the breast cancer associated gene, is a normal tumor suppressor gene, means it helps to damp down the development of cancer. And it's a normal gene in all our cells. But in a certain percentage of people, and that percentage differs with certain populations, there can be a change in the DNA of that gene. We call it a pathogenic variant that increases a woman's lifetime risk of developing breast cancer and ovarian cancer. And there are other cancers for both men and women that is associated with. The people that have the highest risk of having a BRCA mutation or a BRCA pathogenic variant are those that either know they have a family member with that variant, or an Ashkenazi Jewish, and we can talk about what that means, an Ashkenazi Jewish healthy person, or an Ashkenazi Jewish person who has breast cancer, male or female.
Sorry, you just said something that I feel like I want to pick at for a second before I go to my next question. What are the implications if a man has the BRCA mutation?
So I'll say one or two things, and then I'm going to punt that to Michelle.
Yeah.
We do test any man with breast cancer. We do see men with breast cancer. We test any man with breast cancer for the BRCA gene. But BRCA variants predispose men also to developing breast cancer. And then I'll hand this off to Michelle, who can answer that better.
Yeah, it's a perfect segue, because Michelle, what I was going to ask you is about the sort of implications of testing positive. How do you describe this to people in terms of, who should be tested and what are the implications of a potentially, or by the way, what are the implications of a negative test? I think both are worthwhile thinking about.
That is a hugely important topic too, and I'll address that kind of after the implications of testing positive. I think one of the things that is really important to keep in mind, and one of the things that we always tell our patients, is that when we think about these BRCA pathogenic variants, these are predisposition genes, which means that if someone does test positive, there is a significantly increased risk. The greatest risks are for women in terms of breast and ovarian cancer. Men do have an increased risk for breast cancer as well, more so with BRCA2 than BRCA1. But certainly, I don't think breast cancer is on the radar for most men in general. And so we talk about that. New to our NCCN guidelines, we actually say that men can consider getting mammograms if they carry a mutation.
I have this.
So, yeah. There is an increased risk for pancreatic cancer as well with the BRCA mutations, more so for BRCA2. So with BRCA1, it's about 3 to 5%. With BRCA2, it's about 5 to 10%. And then possibly an increased risk for melanoma as well, and then an increased risk for prostate cancer in men. Those are really kind of the main cancer risks that we talk about. And again, I think an important thing that we emphasize is that, these are predisposition genes, which means that if someone does test positive, if they are found to carry a pathogenic variant, it doesn't have to be their destiny. It doesn't mean that they will develop cancer, but rather the risk is higher. And I think that is really where the power of genetic testing comes from. It comes from knowing this information and being able to do things differently. I often tell my patients, we can't change the genes that we've inherited, but we can potentially change the outcome. And so when we think about, what that translates into for someone who does test positive, for women who have a BRCA1 or 2 mutation or pathogenic variant, we are starting breast screening at the age of 25. So we know that cancers that do occur as a result of an inherited predisposition, they often occur at a younger age. And so the goal with our screening and surveillance is to be more proactive, to be doing this at a younger age. And so we talk about increased breast screening, which would include mammograms and breast MRIs. Some women may opt to do prophylactic surgery in terms of a
Mhm.
prophylactic bilateral mastectomy. With the ovarian cancer screening, our screening is not as good. Unfortunately, there are false positives, false negatives. And so for that cancer risk, we really are more directive, and we say, okay, when you're done having kids, by the age of 35 to 40 for BRCA1, 40 to 45 for BRCA2, let's think about getting the ovaries
Getting the
and
ovaries out.
fallopian tubes out. Yeah, absolutely. When we know that our screening is substandard and the symptoms for ovarian cancer can be very vague and it's often
Yeah.
diagnosed late stage, we want to be more proactive and be ahead of that. So we're making that recommendation. I will say I think a lot of people are familiar with the breast and the ovarian screening, but one of the things that I will definitely share that I think is really pretty new, but also pretty exciting, is that we do now have screening for pancreatic cancer.
Yeah.
There have been some studies done. Johns Hopkins has just been an incredible leader in the field of pancreatic cancer research. And we do know from some recent studies that screening in high risk populations, and that usually involves an MRI or an endoscopic ultrasound, we do have the ability to pick up some of these pancreatic cancers at an earlier stage 1 or stage 2. And so there's kind of some differing guidelines right now between the NCCN and a gastroenterology society in terms of whether or not you have to have a positive family history. So NCCN says you qualify for screening only if you have a positive family history. The American Society for Gastroenterology says BRCA 1 and 2 alone qualifies for pancreatic cancer screening starting at the age of 50. That said, I know a lot of pancreatic cancer clinics, including our high-risk pancreas clinic at the university. We offer pancreatic cancer screening to all individuals with BRCA 1 and 2 mutations, regardless of family history. So those are, obviously the prostate cancer screening in men, we're going to start at a younger age. Clinical breast exams, the consideration of mammograms in men as well. We finding out a result like this, certainly is a lot to process for an individual in terms of those cancer risks and what that means for them and their family. But we really try and kind of focus on, okay, this is something that you were born with. This is something that you inherited. You had no control over, getting this gene variant. We can now use this information to be more proactive so that it doesn't have to be your destiny.
Um, Paul, I want to turn to you to take some of what Michelle said and turn it into some of the political policy ethics issues that have arisen around this. Like, what does it mean? What are the implications for a person who is trying to decide whether to get this testing or if they come to have a positive test in terms of some of the policy and ethical issues like privacy? Could they lose their health insurance? What about their family? What are the implications for their family? How do people who've thought about this a lot, as you have and the people at JScreen have, how do you think about those sort of potential risks or benefits? And let's stick for now to the risks and benefits kind of at the individual level. I think we will get back to the question of, Ashkenazi Jew and and what does it mean for the community? But for now, I'm just thinking about for a human being, one person who's thinking about this, how do people put all that together?
So let me just respond to one thing. I mean, people at higher risk aren't Ashkenazi Jews necessarily. They're people with some Ashkenazi Jewish heritage. So you may not identify as an Ashkenazi Jew, and still be at higher risk because you have ancestry in that area. And I think that's important because in J-Screen, which is not about breast cancer, it's about preconception testing. It's about whether people carry things. A lot of people don't get tested because they don't identify as Ashkenazi Jews, even though they carry that heritage. So I just wanted to say that. So this was a much bigger problem in some ways a while ago than it is now. HIPAA, which is, of course, the major legislation that protects our medical privacy, GINA, which is a genetic protection set of laws where our genetic information can't be used. For example, if you get tested as as positive in some way, whether it's BRCA or something else, it can't be seen as a pre-existing condition if you don't have any disease manifestation, according to GINA. So it protects us in many ways from some of the worst possibilities of discrimination from these technologies. However, there are some inevitable results of being tested. One, for example, is collateral information. That is, these are genes that run in families. And very often when one family member gets tested, that information could give information about carrier status to other members of the family, depending on exactly how the disease is manifested in that family. So there are those kinds of issues. There are issues about at what age it's appropriate to get tested. There was a lot of debate. There used to be a lot of debate about whether you could or couldn't test children for BRCA, even though they're not going to be at risk for many years. Is that an okay thing or not? Generally decided that it's not. So there are all of those kinds of issues involved in getting tested. And then finally, as Michelle said, I think some people will opt for prophylactic surgeries, and there are all kinds of issues surrounding that. It's a gamble that you're trying to figure out. What are the odds that I will develop a disease down the line? Am I willing to undergo this significant disfiguring surgery in order to, make my odds much better? Those are the kinds of really difficult personal, clinical, and ethical issues that people have to grapple with.
I want, before we move on, I wonder if you could, my understanding of GINA is that it may not, the genetic information protections, that they don't extend to some things. So like you can't be fired, but maybe you will end up paying a higher premium on your life insurance policy. Is that correct, or has that been fixed? Where does that stand?
Well, my understanding is that unless and please correct me if you have a different understanding, Michelle and Rachel, that unless the test is related to a specific diagnosis, in other words, that it's part of a diagnostic process for a disease, that it can't be used as a disease predisposition. But I don't know, Michelle, Rachel?
We have this conversation with all of our patients, especially if they are, young, they're healthy, they're either testing because of a family history of cancer, because of a known mutation. And, definitely there are a lot of protections with GINA in terms of their employer can't use that against them, and their health insurer can't use it against them. Right. So they cannot be denied health insurance because of a positive test result. The loopholes, though, that we do discuss, that we're aware of, are with life insurance, disability, and long-term care. Yeah. And it's one where if they have policies in place, they're fine. But certainly there have been individuals where they've tried to get a life insurance policy and they've been asked the question, have you done genetic testing and have you tested positive? And so it's I think it's one of the reasons why, we really do believe in that pre-test genetic counseling. There are definitely things to think about beforehand. And, when you're talking to a young woman who's 20, 25 years old, life insurance is probably the last thing on her mind. And so we will often say, if you are thinking about getting testing and you don't have, say, a life insurance policy, get it in place first and then circle back to the genetic testing. And we think about that, with testing other family members. So, and certainly I think we're starting to see some of the individual states have their own laws. Florida passed a law, I think a couple years ago, prohibiting life insurance companies from using this information. But largely, we do know that it is one of the loopholes. So I appreciate you mentioning that, Matt, because it is it's a conversation that we have, and it's something that a lot of people are not familiar with when it comes to genetic testing.
So just to make sure I heard you correctly, so your recommendation is essentially if you're about to get this genetic test, you're thinking of getting it. And I presume this would go beyond BRCA testing to other predictive
Correct.
genetic tests.
Yeah.
Get your life insurance now and then get the test, because once you have the life insurance, they can't take it away from you or
Exactly.
charge you a lot more as a result of those test results. But if you haven't yet bought a policy, you could end up facing a very high price for that policy, or maybe not
Correct.
even being offered a policy at all.
Correct. Yep.
Okay.
Absolutely. And you did just mention something, Matt, that I want to kind of piggyback off of. That is important to keep in mind. I know that we are, we're talking specifically about the BRCA genes. Those are really just two of over a dozen hereditary breast cancer
Right.
genes. We've known about them
And
the
that's just breast
longest.
cancer.
Just breast
Yeah.
cancer, correct, correct. We offer cancer panels of 84 different genes linked to all different types of cancers. Our knowledge of hereditary cancer has changed significantly in really the last 10 years. So yeah, we have over a dozen different genes that we know are linked to hereditary breast cancer. The BRCA mutations in general account for about 40 to 50% of the hereditary breast cancer that we see. But definitely something that's important to keep in mind for someone, who is thinking about testing. And certainly if there is a family history of breast cancer, and you had asked the question, Matt, well, what happens when someone tests negative?
Oh yeah, we didn't get
And
back to that.
yeah,
Thank
I
you.
definitely, I have a notepad with a bunch of little things that I wanted to make sure we touch on. And that, I think, is a hugely important thing to talk about, because many of the people who do undergo genetic testing right now, they are doing it because of some type of family history. And what we know is that 10% of cancer is inherited. Another 20% is what we call familial, where there can be a clustering of breast cancer in the family, but that testing may not tell us anything. It may not explain why we're seeing more cancer. And so when we talk about negative results, it really kind of depends on if we understand what's increasing the risk for cancer in the family. If we have a family history of breast and ovarian cancer, and we know it's related to a BRCA mutation, and then someone tests negative, we would call that a true negative, meaning they didn't inherit that cancer predisposition. Of course, we also know that, half of their genetic material comes from each parent. So we always have to think about, is there something on the other side of the family? But certainly we see many families where they have a history of breast cancer in the family, more than one family member, early ages of onset. And in those families where genetic testing comes back negative, we think of that as uninformative, meaning we have breast cancer in the family and we don't understand why. Maybe it's not inherited. Maybe it's just sporadic. Maybe there is something and we just can't identify it. And so when we see individuals with any type of family history of breast cancer, one of the things that we do is a cancer risk assessment. So basically, we use different models and programs to look at that family history of breast cancer and think about, okay, what does this mean for the person in front of me? What is their risk for breast cancer based on that family history? And many individuals may actually qualify for increased screening, so mammograms and breast MRIs. And we may start screening at a younger age, depending on the age that individuals were diagnosed in the family. And so it's one of the things that we really focus on, because for those patients who test positive, they typically get channeled into, the right clinics. They see us, they've got a team following them. But it's all of those negative results that we think about too, in terms of those individuals could still be at a higher risk just based on their family history.
Yeah. So let's talk for a minute then. Rachel, let's talk for a minute about the implications again of a positive test. So for those people who get channeled in and they end up maybe talking to someone like you about what are my options, or someone in the breast cancer center about what are my options, what do people who test positive, what do they do? What changes? Oh, you're muted.
Sorry,
There's be a Zoom call without that
going on, so I'm muting myself so you don't listen to the drilling. I deal with two populations of people, and I'll be interested in some things Paul has to say. So the most common scenario that exists in the United States is the woman who finds out that she has a BRCA pathogenic variant because she was diagnosed first with breast cancer, and that leads to an investigation of her family history or her age, or there are other indications for gene testing, and then she finds out that she has a BRCA variant. As a general rule, a woman who has a BRCA variant, with or without breast cancer, I like to divide some of the things we've talked about into two areas. One is screening, which means how can we detect a cancer that may or may not happen, and the other is risk reduction. So screening means we're not changing the likelihood of a person getting cancer, but we're going to try to pick it up as early as we can. And risk reduction means what can we do to prevent or lower a woman's risk of ever getting breast or ovarian cancer. We'll focus on those. So I'll say that women who have breast cancer and have a BRCA variant, we treat them the same as anybody else. There are some drugs that are specifically used for people who have a BRCA mutation breast cancer. But the cancer itself doesn't really have a different prognosis, and treatment is pretty standard. However, any woman who has the mutation, if it's a woman, one of the risk-reducing options is a bilateral mastectomy. That almost around 99%, if she's a healthy woman, meaning no history of breast cancer at the time of learning of her variant, will prevent breast cancer 99% of the time. And then Michelle spoke to having fallopian tubes and ovaries removed, and those removed dramatically reduces the risk of ovarian cancer. And interestingly, removing the ovaries also reduces a woman's risk of ever getting breast cancer if she chooses not to have a bilateral mastectomy. So these are some of the things that are done in a healthy person, or these are some of the options. Mastectomies, salpingo-oophorectomies, removal of fallopian tubes and ovaries, and then other things that are risk-reducing interventions can be taking anti-estrogen pills. That's more beneficial for a woman with a BRCA2 variant than a BRCA1, but it can help a BRCA1 as well. There's an international study with an infusion of a medicine used to strengthen bones called denosumab. It's 2 infusions twice a year for 5 years. And there was a fascinating study in Israel, which most people don't know about. It's not yet standard, where women who were treated with radiation for breast cancer on one side could opt for radiation on the other healthy breast in women who had the BRCA variant. And that radiation to the other side reduced breast cancer by 80%. Now, that was in a phase 2 trial. It needs to be moved forward into a phase 3 study, and my colleagues in Israel are working on that. But that is an exciting future option that hopefully one day we'll have an answer to.
That is so interesting, because
Very
I
cool.
will have to say, if you had told me what do you think is going to happen if you take a person who has a tumor suppressor gene that is dysfunctional, therefore they are more susceptible to tumors, and then you radiate them, what's going to happen? I would have said they will have more cancer, because you're giving them radiation, which creates, the possibility of tumors, and they're missing this gene, and yet it's exactly the opposite. So I'm dying to learn more about that.
Correct.
Yeah. Paul, let's turn back to you in this question about Ashkenazi Jewish.
Mhm.
I do want to hear more about, so what exactly does that mean? What are the implications of being Ashkenazi Jewish? Obviously, it doesn't have anything to do with, your religion, Jewish, but to what extent do people know they're Ashkenazi Jewish? Who counts as being how Ashkenazi Jewish, right? Like if your grandfather was Ashkenazi. Yeah, so
First of all,
tell me more.
Ashkenazi Jews are an ethnic group that are identified primarily from a common ancestry, though people, for example, adopted into Ashkenazi Jewish families may still identify themselves as Ashkenazi Jewish, even though they don't actually have the genetic history, because it's also a cultural group. But there was a very strong founder effect in Ashkenazi Jews. And what that means is that in the 14th century, about 30,000 Ashkenazi Jews exist, from whom all current 10 to 11 million Ashkenazi Jews are descended, which gives Ashkenazi Jews a very strong commonality in their DNA. And that means that a lot of diseases are common in that population. It also means that that population was a very good population to study when you're trying to figure out which diseases are caused by which genes. So to give you an example, early on, before there was GINA and HIPAA, I was called to a meeting in Washington with Richard Klausner, who's the head of the National Cancer Institute, and Francis Collins, who's the head of NIH, to discuss the question of whether or not Ashkenazi Jews should participate in research to identify disease, because there was concern that if they did identify the diseases that were more genetically common in Ashkenazi Jews, that we'd suffer insurance discrimination, right? So those were very real kinds of concerns. Ashkenazi Jews and having Ashkenazi Jewish ancestry in almost any line can result, if it's a consistent line, can result in having a BRCA mutation. I don't think we know when it first was mutated and how far back it might go before that was part of the Ashkenazi. Maybe Michelle or Rachel knows. But for people today, if you've got Ashkenazi Jewish background at all, it's worth considering that you'd get tested, not to mention the fact that Ashkenazi Jews aren't the only ones who get BRCA. It's higher than in the average population in certain Hispanic communities and in other communities. So, and of course, there are a lot of people who have no idea that they have Ashkenazi Jewish background.
Can I just interject and sort of just expand on that? So yeah, that's really helpful, Paul, and thank you for correcting my my statement about if you're Ashkenazi Jewish. Right. So just to put it into risk numbers, so they've done studies. One of my colleagues, Efrat Levy-Lahad in Israel, did a very clever study where she enrolled men with no cancer history with 4 Ashkenazi grandparents, Ashkenazi Jewish ancestry in all 4 grandparents, and documented that the rate of having a BRCA mutation is 1 in 40. So for any Jewish person in the United States, if you meet a Jew and you don't know anything about them, the likelihood that they have Ashkenazi Jewish ancestry, 70% of them are from Ashkenazi Jewish ancestry, where in Israel it's about 50-50 as far as the ratio. Yeah. And in the old country, in Poland, Europe, Germany, France, where Ashkenaz was, we were very inbred. And in modern society today, Jews don't necessarily marry Jews. Ashkenazim don't marry Sephardim or people from Yemen or all over. So it is correct that that number 1 in 40 is going to dilute as the Ashkenazi population, the Ashkenazi ancestry population, intermarries and has children with people from other ancestry. So that's just where we start. The average person has a 1 in 300, maybe 1 to 400 chance of having a BRCA variant, but it's 1 in 40 if you're Ashkenazi Jewish and healthy, male or female. So this isn't a gene that is passed only from mother to child. It can be passed no differently from father to child. And if you have breast cancer and have that 4 ancestors of Ashkenazi Jewish descent, that rate goes from 1 to 40 up to 1 in 10.
I want to get, because I know we're going to have a bunch of questions. We had a bunch submitted beforehand, and we have some already popping up in the chat here. So I want to start getting to some of those. I'll go back to the pancreatic cancer question again. That was intriguing to a number of people, especially the idea of screening for pancreatic cancer. And I guess one of the questions is about, beyond the BRCA, I think you mentioned a couple of other ways for screening for pancreatic cancer. Can you just repeat those? Because there were some questions in the chat about that.
Yeah,
Michelle.
typically the recommended screening programs use either a yearly MRI or what's called an MRCP. It's basically a focused MRI of the pancreas. So an MRI or an endoscopic ultrasound. And an endoscopic ultrasound is basically going to be, it's going to be a more invasive where they use a scope to look at the pancreas.
And the other part of that question was, would that only be for people with BRCA positive results, or like if your mother had pancreatic cancer, is that enough to warrant getting that kind of screening?
It's a great question. So we have a number of different gene mutations that increase the risk for pancreatic cancer. BRCA, the Lynch syndrome genes, ATM is another big one. There's a hereditary melanoma pancreatic gene, which is called CDKN2A, and some other less common ones. Those gene mutations, with or without family history, may qualify someone. But one of the things that we talk about, kind of like when we have multiple family members with breast cancer in a family and that genetic testing comes back negative, there still may be something going on and we just don't know what it is. And so right now, individuals who have 2 or more family members with pancreatic cancer, with one being a first-degree relative, even if genetic testing comes back negative, they would still qualify for pancreatic cancer screening. And again, that's usually starting around the age of 50. It may vary, though, depending on the age of diagnosis in the family.
Rachel, I think there's another one here that's probably for you about cost effectiveness of these different interventions. Someone's asking if there have been cost effectiveness studies looking at so there's obviously what Paul mentioned, which is sort of the psychological benefit of knowing that you have dramatically reduced your risk of cancer by doing prophylactic bilateral mastectomies if you're positive for BRCA 1 or 2. But does it also save the healthcare system money?
So there have been studies looking at that, and it is definitely a cost-effective intervention.
Okay. I want to get to something that that has kind of been implied here, but I want to make it explicit, which is when you get this testing, are you getting just BRCA testing, or when you get genetic testing, is it genetic testing for a whole bunch. Like, are we doing whole genome sequencing now and looking at everything when you get genetic testing? Or what, like, practically speaking, what's actually happening when you come and talk to, your doctor and say, I'm worried about I have Ashkenazi Jewish heritage. I'd like BRCA testing. Can you get that by, logging on to Ancestry and sending in a cheek swab? Cheap, also a cheap swab.
Rachel and I are both grinning. Do you want me to take this one,
Yeah,
Rachel?
go ahead, and then I'll jump in afterwards.
I will say there are ways to do genetic testing on your own. It's called direct to consumer testing. We really encourage some type of pre-testing consult, whether it be with a genetic counselor or medical provider. We have nurse navigators who are doing it, some of our, breast oncologists. I think having a conversation before genetic testing is so important for many reasons. One, we have different levels of genetic testing that we can offer. Certainly in terms of the patients that I see, we are focusing on cancer specifically. There's a lot of testing out there, though, for a lot of different things. It just wouldn't be in my wheelhouse. But even within the cancer realm, there are, different levels, different panels of tests that they can do. And, I think the one thing that you realize, and certainly this gets into, some of the ethical considerations as well, there is no right or wrong answer to any of this. Some people come in and they say, hey, I'm a data person. I want to know as much as you can tell me. I want to be tested for that 84 gene panel. With of course, with the disclaimer that when we test for a huge panel like that, we might be testing for
Something's going to be positive.
Well, not necessarily that. Certainly it increases the likelihood of finding what's called a variant of uncertain significance, where we don't fully understand what it means right now. But testing for genes that maybe we don't know as much about. Mm-hmm. Some individuals say, I don't want to go down that rabbit hole. I don't want to open up Pandora's box and be testing for things that we don't know a lot about. And so we talk about kind of those different options for testing. A more, targeted option would be if there's just breast cancer in the family, just looking at genes linked to hereditary breast cancer. We see a lot of individuals kind of go for this middle option where we're testing for, anywhere from 47 to 60 genes, that it's a broader test. So we're kind of casting a wider net, looking at common hereditary cancer genes that are considered to be clinically actionable, meaning that we know what these genes do, and we're going to have information for the family regarding what that means for them and their family.
A couple of things to add to Michelle is that we have indications for breast cancer gene panel testing. We usually recommend panel, so not just BRCA1, HCA1, 2, a few other genes. But if those are not indicated, the issue is that your insurance won't pay for it. And now if you still wanted to have that information, really it's not that expensive. You could get it for around $250, I believe, Michelle, or less.
Yep.
So a person who doesn't have you don't have breast cancer, you don't have a family history, you're not Ashkenazi Jewish, whatever, strongly, you can still get that information for relatively not a lot of money. And then I'd like to move, it's also a question, but get Paul involved, is I also don't think there's a reason to get genetic testing unless you're willing to do something about it. Because if it's just going to cause you stress and anxiety, and you're not willing to get an annual MRI, or you're not willing to consider surgery, you're not willing to tell your children or your family, that information isn't doing you anything, and I don't see the value of it. So people ask me all the time, I'm an Ashkenazi Jewish cancer survivor. I don't have the BRCA variant, but I live in a religious Jewish world that's very strongly Ashkenazi. Should I get tested? And so to me, that's the first thing is, are you going to do anything with that information or not? And if the answer is not, then I don't think, even if you meet every criteria for insurance coverage, it's worth doing.
I love that you added that, Rachel. Thank you, because that is one of the things that we've really emphasized. And I will say the other thing that I think it would, which is why kind of a pre-test conversation is so important. The idea, are they doing genetic testing to test for the negative result? Meaning that they're just assuming it's going to be negative and they can cross it off the list.
Cross it off their list. Yeah. Things to worry about.
Exactly.
Yeah.
And for many individuals, that is the case, but it's not always. And we have to think about, what would you do if you tested positive? And just as you said, Rachel, that is a huge piece of our conversation. You know, if you test positive, what are you going to do with this information? It has, genetic testing is so different than any other, you know, this isn't looking at cholesterol or glucose. This has implications now for the whole family. And so
Paul, I'm wondering if you can comment. Let's say you're a single
woman. I would love that.
Yeah, let's say you're a single woman in the dating world and you know you're BRCA positive. You know, maybe you can talk about, is there a way to prevent it? Or afterwards, maybe Michelle can talk about ways to prevent transmitting it to the next generation. But Paul, can you share with us some ethical scenarios that you deal with?
So let me say something about what you said, Rachel, and that is, the ethical principle that you articulated, that people shouldn't get tested unless they're planning to do something about it, is extended to a broader question about genetic testing. What if we have a genetic test for something where there is nothing to do? And the general consensus is, don't test for that. I mean, the information itself is not a valuable enough commodity for the negative consequences it might cause of anxiety and stress. But that is an ethical question. I mean, I might say, I don't care what you healthcare experts think. I want to know if I have a genetic, it's my genes. I want to know if I have a genetic propensity for anything. Test me for every human thing that we know how to test for. So, you know, again, I think all four of us might say that's not a wise thing to do, but it is an interesting ethical question about whether I have a right to do that if the technology exists. I think people underestimate how much anxiety it will cause them. I'm so glad you said, Michelle, that people have to imagine what it's like to get a positive, but even when they imagine it, they often don't realize how much stress and anxiety it's going to cause them knowing this. And it implies, you said it implies familial knowledge, but also reproductive knowledge, right? So someone finds out they're a carrier of something, and all of a sudden it begins to have implications for whether they should reproduce or how they should reproduce. And there are plenty of, we can do pre-implantation genetic screening now, where we take fertilized embryos and we test them for various things. And because now we have, you know, when I started at JScreen for preconception testing, they were testing for 9 genetic syndromes when I started, 9 genes. Now it's over 200. And their cancer screening, which came later, now tests, I think, for 73 or something like that. So we, you know, we've gotten so good at this that it's easy to test for lots and lots of things, but there's also ethical problems with testing for that level of things. And we see that in medicine in general, where as our tests get more sensitive, you know, we want to intervene because we found something, even when maybe that's not really the right thing to do. So that principle, the question of what do you do with information, has a lot of ethical and social aspects to it.
You all, and some of the questions are in the chat are also reminding me of this issue of a test may mean more or less than you think it does. And it reminded me of the ApoE4 story, which I'm sure all of you probably remember from a few years ago, when ApoE4 was being used as a screening test for cardiac disease. And then it also turns out it's a screening for risk of Alzheimer's disease. And it turned out, we were inadvertently, in some cases, finding out that someone has pretty high risk of getting Alzheimer's disease. They may not have wanted to know that.
I always tell the story. What would have happened if we had tested if Ronald Reagan had put out his health information and had an ApoE test to show how healthy his heart was. And then during the campaign, they discovered that it also tested for Alzheimer's. It could have changed everything, right? Yeah. So these tests are not benign. They often have really strong implications for all kinds of things.
Right. Some of which we don't know yet.
Yeah.
Probably most of which we don't know yet. There's a question specifically for you, Paul, that came in one of the RSVPs. Do you know an organization called COCO? It's apparently a partnership with Emory, COCO, all capitalized.
No.
Okay. We'll have to Google it and find out.
Yeah. I don't know.
And then another one that's come up is around how Ashkenazi is Ashkenazi again, and who would you recommend? If you have one great-grandparent who was Ashkenazi Jewish, and as far as you know, no others, would you still recommend proactive BRCA testing? And I guess that's to any of you. Maybe Michelle, what would you say to someone who comes to your office?
It's a great question. And I was actually, I know one of the things that we've been talking about in terms of like kind of who qualifies for genetic testing. Certainly our threshold is different if the individual does have Ashkenazi Jewish ancestry. So,
and at any level.
If they have breast cancer, yes.
Yeah, of course.
For one of the kind of new NCCN guidelines is that if an individual has Ashkenazi Jewish ancestry, and they basically define that as even one grandparent, so 25%, they could consider genetic testing even in the absence of a family history of cancer. So, certainly if we're seeing someone with a history of breast cancer, colon cancer, prostate cancer, we have guidelines that kind of help determine who qualifies for genetic testing. But the newer guidelines, with the way that they are written and knowing that these BRCA pathogenic variants are found, more frequently in individuals of Ashkenazi Jewish ancestry, it is a conversation that they could have with their provider in terms of, is this information that they're interested in learning? We've got a lot of technology. We don't touch the whole genome sequencing, Matt, to answer your question there. I had the opportunity to have my whole genome sequenced a number of years back, and I said, no, thank you. I did not even want to go there. But, I think that for those of us who have been working in this field for a long time, we've got a lot of technology. We really do. We have the ability to test for a lot of different things. And there is no right or wrong answer. There really isn't. And what is the right answer and a good fit for one person may not be, the right answer for another person. And so it really is a personal decision. And we even see that within families where, individuals may choose not to test.
Although I guess within a family, some of the information is sort of forced upon you if one person chooses to test and gets a positive
another
result.
Family member may only have a 50% likelihood.
Yeah.
Right.
Yeah. It's not definitive information, but it's some information that you can't avoid.
I will say one of the things, I was recently doing a talk on kind of what we call cascade testing. It's our fancy way to describe testing in families where there is a known mutation. One of the things that some individuals don't realize is that if you have a family with, say, a BRCA pathogenic variant, And, say you have a sibling, they're at a 50% risk to carry it, and maybe they're just not ready to do genetic testing yet. Maybe, they don't have life insurance in place, or just, emotionally, mentally, they're not in a place where they want to learn that information. That risk alone qualifies them for increased cancer screening. And so, yeah, it's something that I don't think a lot of families are aware of, that if there is a known mutation in the family, if
You don't want to
someone,
be tested
you don't
for
want,
that mutation, you can still get enhanced screening regimens.
you could,
Huh.
obviously where it gets tricky, Matt, is if, say, that person is at, they're 40, we're talking about having their ovaries out. Now we are talking about an invasive procedure with risk, to where
Yeah.
knowing that information would probably be helpful to know, do you truly fall into this risk category where it would be indicated, or are you negative? But, certainly we see individuals where maybe for a few years, while they're not, sure if they want to be tested, they might just choose to do screening for a while, knowing that they have that risk.
Yeah, I want to make two quick points just so to clarify for our listeners in case they don't realize this. There are about 20, 25, depending on how you count, genetic diseases that Ashkenazi Jews are at greater risk for than the average population. That doesn't mean they're not at risk for a whole bunch of other diseases at the same rate as the general population, and some Ashkenazi Jews are at a lower rate than the general population. The ones we tend to focus on are the ones where Ashkenazi Jews have a greater incidence than average, but that doesn't exempt us. I'm one too. That doesn't exempt us from other diseases as well. So that, I think that's important just to make sure everyone understands. And the second thing is Sephardic and Mizrahi Jews have their own group of diseases that they tend to have more than other groups. There are fewer of them. It's about 7 or 9 in both of those cases, as opposed to 20 in Ashkenazi Jews or so, round numbers. But there are testing palettes for Sephardic and Mizrahi Jews as well.
Thank you. And we're getting really close to the end, but I think we shouldn't end without first making an acknowledgement that there are presumably reasons, in addition to the fact that Ashkenazic Jewish populations are, sort of genetically more homogeneous. There are a lot of genetically homogeneous communities around the world, and Ashkenazic Jewish community has allowed essentially for a lot of research to be done in that community, partly because that community is very involved in the medical system. Lots of doctors, right? People who for reasons that we've talked about in prior episodes of this series, there is a disproportionate sort of interest in the healthcare system and in becoming health professionals and contributing to the research arena. So that's one thing to mention here. And then the last thing I have to mention is we will be sending out a survey. Please fill out the survey. We take it very seriously in terms of crafting future programs. That survey will come to you as a link in your email, but I think we will also put it in the chat probably right now. And I want to thank you. I also want to end by thanking once again Helen Morris, the primary supporter of this program on the American Jewish Experience in Medicine. If you found this program valuable, please sign up for our mailing list and keep getting invitations to future programs. And of course, you're always welcome to send a donation to support the ongoing operations of this really pretty unique program around the country and around the world that sort of celebrates and teaches about the legacy of Jewish people in American medicine and in medical science more broadly. Thank you again. We are right at time according to my clock, so we'll sign off.
Thank you, Matt.